Okay, so the piece that we're going to move into now is just thinking through that, the roadmap, what needs to go into it, whether we've got the right pieces. I'm going to flash through some of these quite quickly and then just get you into some action. So we've got within the roadmap, what we've tried to capture from the last workshop is some things around what's been going well, what it would be even better if across these three sort of work streams. One's around infrastructure, one's around intelligence, and one's around interventions. So there's lots we captured so far. There's a load more that's come out from today. So we'll pick that up, we'll build that in, and we'll make sure they're added. We've picked up a number of pieces around what the actions that are there around sustaining current work within PCNs, what's needed, and what's the additions that would be needed to kind of spread what we've done. And there's some things around sort of potential risks. So what are the things that might get in the way? How do we keep one of them being around? How do we make sure resources are protected to do some of this work? How do we make sure that we've got that kind of linked data set so that clearly this isn't all about data. It clearly needs a massive piece around using the local knowledge and intelligence to triangulate with the data to look at where you should go, but having that sort of single source of truth feels an underpinning essential piece. And then some things around what's the system need to do to either support or get out of the way so that neighbourhoods can drive and own and keep moving forward with this. I'll do those really quickly because the bit that we want to get you into now is there's some detailed actions below each of those pieces around infrastructure, intelligence, and interventions. So we're going to give you a couple of tables each, one of those three areas, so you can look through the detailed actions that we've captured so far. And then what would be really good would be just to get your input onto whether they're the right actions from the conversations today, what have we not captured so far, where are the gaps, scribble those down, and then we'll get a quick bit of feedback on those, and then we can build those in so that it's so the actions that are in the roadmap are the actions that you guys want to take forward to make this work, rather than some things that we think might be quite a good idea. So we'll do it in this way. You've got some packs on your tables, which are A3 sized. I think, no, Harry's handing them out. And so when we do this, just bear in mind, we just want you to have a look at one of the subsets. So either have a look at infrastructure, or have a look at intelligence, or have a look at interventions, because otherwise it's just going to be too much detail for everyone to get through. And these might be some prompts to have a think through when you're doing it. So one's around whether the roadmap's got the right things in to sustain what you're doing, whether it's got the right things in to scale it, what would make others want to be involved in it. So we'll try and do this for about 25 minutes. We'll see where you are at 25 minutes, and then we'll get a bit of feedback.
Okay, folks, thanks very much. So what I'm going to do, obviously the ICS leads have been doing a lot of thinking and work on their table. I'm going to save their feedback and reflections to the end. But what we're going to do is I'm going to go table by table. You've each had components of the PHM maturity matrix. I'd like someone from the table to feed back thoughts, reflections. Are there actions that are missing? Are there any other comments you would like to add? And also, Harry, who's helping us write all this up, will need those. If there's one version of it that's legible, that would be really great for Harry. But he's going to capture some of the stuff up here as well. Sakti? That'd be great. And then I'll just take any questions of clarification or immediate comments from the ICS leads. Is that okay with everyone? Yep. Now there's another mic doing the rounds. So what about starting? I'll scan backwards and forwards and bring it forwards. So what about at the back here? Just tell us which components you had and actions and comments.
Okay, so we looked at intelligence as the intelligence group. I guess a bit of background. We looked at those things that we thought we'd gone well and what hadn't gone so well before we looked at actions of what to put in place. Positives, we think we got to a place with a shared data set, and that was really, really good, but it was done for the specific purpose of the 20-week programme. We think that the issues going forward, we've got obviously the issue around data quality, properly linking the data, including all the data sets available, such as primary care, things around where the data's stored, and obviously fully linking the data as well. So for us, rather than going into the next stage of another 20 weeks, we thought to take a step back, look at actually what we'd learnt as a BI community, and come up with a set of options, guys. Look at what we can do to robustly support the system. So rather than putting something in place now that would be how do we sort of incrementally do this, take a step back and say from a data perspective, from an IG, from an analysis delivery perspective, how do we get this right to fully support the system? From that, to come up with a set of options, so an options appraisal for the exec, with some recommendations to really set out to get this right and get this right once with full IG, shared data set, et cetera, in place. This is what we need to provide for you with some so then to look to the exec to then take that on board and give us permission to then do that along with the resources required to deliver that as well.
Okay. Any immediate thoughts or reflections on that? Gary.
Agreed.
Thanks, Gary.
It's obvious it needs to happen. But what I'd say is that the resources provided to CCG BI providers, which is the CSU, is paid for by the CCGs. So, what this requires is that conversation between colleagues at the exec colleagues that work on a Lancashire and South Cumbria wide basis and our commissioning leads within the CCGs. What we were talking about earlier on was turning off some of the stuff we currently do that probably isn't as much added value, like contracting and performance monitoring, trying to do that more efficiently so we can divert the resources into this area. But we need the agreement of the CCGs to be able to achieve that. But that doesn't mean to say that as the ICS execs, we wouldn't want to have that discussion with our CCG colleagues.
Okay. Sorry. Yep.
So just in answer to that, Gary, don't forget we're not all exactly the same. Some of us, our CCGs, haven't got CSU embedded staff, so we just have to make sure that those BI analysts are included in that too and have discussion. For me, though, as well, it's about in this roadmap, can we systematise some of the things that we're doing so that we can all have access to a bin collection? Let's think about, if bin collection is the next thing we want to do, how do we all do it together? And maybe we all look at, is that the next thing we need to do? For me, it's about linking some of the other things too. We've all had to do the asset mapping as part of the estate strategy. How do we collect that data and maybe layer that? Some of the things that we've already got, let's get a system plan for maybe how we do it. And the other thing that struck me from some of the presentations, the segmentation. Somebody mentioned Acorn, I think somebody else mentioned Mosaic, and I think some of us have also used Dr. Foster. Should we also have one version of risk stratification segmentation that we're all using? Because otherwise, whatever this intelligence is, this data we're collecting, it'll be very different in very different places.
Okay.
There's a real food for thought there, Jackie. We haven't even done proper population health management. Sorry to say that, but actually this is just the beginning of what might be the art of the possible. Just in response to the intelligence table discussion, whatever we do, we can't stop what we currently have done to share the data between the various. I know we've done that for the purposes of the 20-week program, and it'll be a travesty to stop that, actually. So we need to find a way of continuing that while we work out the options, appraisal, and all of that. And a really good point about systematizing the products, as it were.
Okay, folks, because of time, and there's quite a lot, this is richer than, it's going to be really difficult to facilitate for me because it's so interesting, but I know that we are on a tight timeline. But what I've heard the ICS say is they are now fully committed to a single source of truth, and what you need to do is tell them how quickly you can get that done. Actually, I'm joking apart. What's the timeline? When will it be done by? Who's going to do it? Who's accountable? Who's responsible? Who needs to be consulted? Who needs to be informed? Now, some of this is a bit kind of PMOE, project managing, but that's what the roadmap is about. It's about actually, it's not time. I don't think it's time to step back and reflect and take a long time. There's a sense of urgency about this that I want you to keep going with. And the reason a 20-week cycle, it's really interesting. Having a 20-week cycle meant we just had to break through things and get things done. And so there's something about agile methodology, or whatever you like to call it, about really setting yourself tight timelines. That's what I would reflect back. I don't, I've heard these sorts of conversations before, and then it's kind of got mired, and it hasn't got done. So if you're going to do it, you need to put some timelines, responsibilities, and accountability to it. That's all I would say, and that's what the roadmap has. Sorry if I'm going to be really challenging, because this is a wicked moment for everyone in the room. Is there anything else from that table?
We'll take the challenge on board, and we are deliverers, so we will deliver.
Magic.
Just as a point, just on to what you said, Gary, there's also, it's not just about CCGs and funding the CSU, the business intelligence community is wider than that, so that is other partners that need to be involved and free up that resource as well. It's not just a CCG funding issue, it is a system issue as well. Right,
okay, thank you very much. What about, who's next? Anyone on this back row here? Or what about here? Any comments?
So we were looking at infrastructure, and that means primary care capacity, capability, primary care development of the networks, data maturity, leadership, analytics capability, etc., etc. We think we have noted additional points to these, but I think some of the ambitions noted already are fairly ambitious. If we can just deliver them, we'll have already achieved massive inroads into.
That's a really interesting point. So, what reflections on that? If we can deliver what is down there already, that will be fantastic. Any thoughts or reflections at this stage? Yeah. Okay. Yeah, no, so yeah, a really great point is how do you go, well, so the phrase a mile wide and an inch deep, or do you go an inch wide and a mile deep? How far do you spread yourself to actually create change? What will be effective? Thank you. Anything else from the table? We've got your notes and comments, have we? Yeah.
Could I just mention something as well? I'm here.
Yes, please.
There's, I think if we're looking to shift resources and capacity from the acute back to the community, I think one of the things we need to take account for is the transition period. There's going to be a period of double running, and I'm not sure if that's been addressed yet, because as if you're closing one facility to another, I know it's not closing a facility, but from transition from A to B, there's got to be an interim step where there's going to be some parallel and overlap between the two systems running side by side.
I agree, but maybe there's something about communicating what's coming in differentially over the next 2 or 3 years. I don't know, Jackie, the central funding for development of PCNs, it seems to me, and I don't have all the numbers and figures in my head, but I remember in one other place we did some work, people said, well, there isn't much resource to do all this. And then we calculated all the different things that were happening to support it. And when you put them all together, there was a substantial resource, just people didn't have visibility of it. So is there something about really making clear the resources? Because there's a lot of money coming into PCNs over the next year or two. Yeah, Jackie.
Seeing as you put me on the spot there. I think that's right. There's been quite a lot of work done in different systems to map, for instance, In Manchester, they were looking at how much public health resource they had across their 10 localities, and if they actually brought some of that together, the power they could have to release that to actually support neighbourhoods with the changes rather than everyone keep doing a bit of it. In Surrey, they've pulled together an Office of Data Analytics by doing the same with their analytical team. So instead of lots of different people sat in a hospital, in a CCG, etc., how do we raise that up into a function for a system? And I go back to, I guess, the previous point we had around looking at what the system levers, incentives and enablers are, not just the barriers. So what is it that you've already got that you could maximise to make this happen? I think you would find you had a huge amount of opportunity if you looked at how to align it all in the right way to do this and to stay in this and to embed it.
Okay, thanks, Jackie. And this is I'm not trying to make it sound easy, because it ain't. But you have the potential, and it's kind of, how do we help you unleash it? So anyone else at the back that needs to make a comment on these back tables? What about over here? I know there's some work going on here.
We looked at infrastructure as well. We touched on a couple of things that have already been mentioned. But just to follow on from what Jackie's just saying there, one of the things we talked about was there's questions on this A3 sheet about risk stratification, segmentation and modelling the impact. We talked about how do you align some of this to incentives and contracts, including where there's going to be some shared incentives, particularly around integrated care, partnerships, MCP, whatever each area may be, as well as at practice level. So that may be something to reflect on. And the other thing, a little bit more of a general reflection, but it's hard to see sometimes in here, it's your point, Martin, about whose responsibility is it? Because you run the risk of people assuming somebody else is doing it and nothing really moving forward. And in that, there's some actions around develop structured approach to enabling neighbourhoods to define their plans. Well, whose responsibility is that? And actually, for local ownership, do we need to develop a structured approach, or what is in that structured approach? Because I think what we've learned is there's power in the neighbourhood being quite organic about how some of this develops for local ownership as well. So we may need a bit of a PMO approach, but a little bit of flexibility to allow this to come from the ground up so it really does embed and it's got roots in each of our neighbourhoods as well.
And thank you very much. Any reflections on... Well, have I got two mics there? Any reflections from the front on that pertinent point about, do you have it? How didactic are you? How free are you? What's the balance?
I'm just going to really agree with Lucinda's point, and that's not because I'm scared of her. But I think she's absolutely right in that there is a danger that this can appear too top down. And I think there's also a trick, and again, Adrian and I have this conversation regularly around how do you hook a PHM approach to what networks and neighbourhoods already have to deliver via that DES. And again, one of the really logical and sensible things to me is we've all got to appoint social prescribing link workers. How are they going to identify the cohort of patients that they are managing? And again, for me, logically, a PHM approach will help that. I also think that I'm not convinced another 20-week cycle is the right thing. I think it's probably about embedding this approach and identifying, again, some local priorities that networks have identified, or some asks via the DES that we can link the PHM approach to.
Great, yes, please.
I suppose I agree with some of that. I think I raised last time when we were here, sort of what's the role of the ICS, what's the role of the ICP, MCP, and what's the role of the PCN. For me, I do see this being a bit like right care, where maybe at that ICS level, we identify the opportunities. So the opportunities for the MCP, ICP, how much could we save if we were all doing respiratory in the same way and had the same, and that's why I was talking about risk strat, or segmentation, the same segment costing the same thing, how much could we all save? Then it's down to the PCNs to make the decision, sort of how they then go ahead and treat that cohort.
So I want to add to that by saying I think one of the things with this is how we use our language or how we ask our questions can be really enabling, and it can be really disabling. And we've seen it with a number of the things that we're doing around change. So someone like me can say something where I might be talking about neighbourhoods, and people working in neighbourhoods say, oh, the ICS get it. And then I might say something about the ICPs having to take responsibility, or the ICS having to take responsibility. And people think, oh, he doesn't get it at all. And I think one of the reasons I agree with Peter, what you've just said, if you listen to the advisory board colleagues, they're basically saying we are exploring many of the same questions that many of these systems are. How do we take risk, think about population health, and then segment the approaches that we have? And how do we keep that organic enough so that people at the front line who really know what's happening in their communities continue to feel empowered? Now, that means people in roles like mine feeling like that we're at the bottom of the pyramid, not at the top of the pyramid, which is why some of that earlier slide was really important. But it also means that when we've got a really kind of precious resource that we happen to call business intelligence or analytics, that we're not siloing that or asking you to silo it. We're getting the right skill mixes at the right levels. And we've not been good at that. And we've kind of compounded it by transacting relationships with CSU or focusing on contracting. And breaking out of that needs some time and care and some really, really good questions. And then we'll get the right level of action at the right level in the system. I think that's what we need to do over the next 20 weeks or so.
So maybe it is the words, but maybe at the moment... Maybe at the moment I'm not seeing that being transacted the way that you're describing. So maybe we just need to work through that a bit more.
Thank you. Thank you. So, yes, ma'am.
I
learn fast.
I'm going in a minute, so you're all right. So in a way, that's kind of maybe sort of helped my point around that some of this that says develop this, develop that, develop the other. I don't know that it's one answer or the other. In some areas, a 20-week, or a 15-week, depending upon where they start, or maybe a bit long, may work. And I think different areas have found some value in the intensive, accelerated approach. Whereas for some other things, or some other geographies and neighbourhoods, it may not work. And so I think just that little bit more sort of us being comfortable, a touch more flexibility than some of this about what's right for each neighbourhood, because it is likely to be different, and that we consider that rather than saying we're going to do it this way.
So this stuff is really easy, and I think it's reflected in the fact that I read a book recently about that said there are only 432 change models. So obviously making change happen is dead easy. This is really difficult stuff.
Why have you ended up with two microphones?
Because I'm about to hand one to here. I'm incompetent at delegating, haven't you noticed?
Andrew, I know what you mean about being at the bottom rather than the top. I think they call it the mushroom syndrome. So I had the joy of being on Team West Lancashire, which was really good. I think we were talking about intelligence. However, because we had the guru here of actuarial and modelling on our table, the group took it upon themselves to educate him about how we might come up with mitigated actions or transactions that might help us. So we focused on Ruth's husband, to the point where she's gone home. And we explored a number of things, but we connected them back. So we were looking at it from the kind of frontline perspective and how you use actionable data. So I think the analysis, or sorry, the baseline plan that's in here, people were in agreement with. There was some interesting points that came out. One of them, I've completely forgotten about SACFI, which is about when we talk about doing the modelling and then basing it down to communities. In communities, shouldn't we be giving this data to those communities, not the professionals, but to the communities? So how might we democratise data? So I thought that was a really, really interesting point.
Wow, I didn't think it was going to get this radical. Comments? Sandy?
Yeah, we have talked about it, and I'm not forgotten about that. In effect, as of last week, David showed us how you get to the details of the mitigated scenario. And what's very clear in that is you can't just do it with just analysts or just things plucked out of air. it has to be done in a very democratized model of you get people who are going to actually use the interventions or receive the service, which includes members of the public. But it's a very, very exciting field, because that's where the real change is actually going to happen. So if people trust in the social prescribing for people with respiratory disease, that's going to keep them better. There is a human factor in that, which is quite hard to model. But that's where the mitigated scenario and the power of agreeing that locally with people who are going to be engaged in that is really, really important. And sometimes the other side of that is not invented in Skelmersdale syndrome or Fleetwood syndrome. That can happen, because if you don't really participate in that methodology, you don't trust it. So that is a really hard nut to crack in that sense.
Yeah. There's a great phrase someone once gave me, which is talent imitates, but genius steals.
There was one other point, just connecting back to that, which I think is important, which was we're talking about the group sessions. And if you were taking that data, so we already kind of had a glimpse of it today about how they were putting up the scores, anonymised scores. So I think there's something here about this data coming back, being used within, contextualized to the intervention. And again, something to explore as we go forward.
Okay, thank you very much indeed. I'm going to... Yes, Gary. Yeah, please.
It does seem to me that the ICS and the ICPs need to treat the primary care networks, the neighbourhoods, as clients. So there's an offer to be given to the primary care networks and the neighbourhoods to enable the neighbourhoods to take these new opportunities that we're identifying and applying them to the right people. That's really what it seems to me to be about. So what is the offer? And how does it become an offer that is responsive to what a neighbourhood or a primary care network needs, without it feeling like a primary care network's got to radically change everything it's ever done, because that's not going to happen. So what is that offer, and how can it be adaptable enough to meet needs of different primary care networks, which will develop at different speeds?
I agree. The one thing I would say, and it's a really huge challenge, with a give comes an ask. And there will be whole system issues which we can give you this, but our ask is you've got to help us with this. So, and it's reconciling that tension. It's so, that's why you have to have great management, which I think, feels like you've got the potential here.
Just a really quick comment. Again, agree with what Gary said. I think the trick is as well for us to integrate that offer. So at the moment, PCNs are receiving offers left, right and centre. For PHM, there are a lot of different partners around the room today who have skills to offer in terms of an integrated approach to PHM. We need to integrate the offer to the networks.
So what you're saying is, if I interpret it correctly, NHS England, can you take an integrated care approach to the system?
And with CCGs,
yeah,
LMCs, local authority partners, voluntary sector partners, etc.
Yeah, very straightforward. Okay, good. Yes. Should we come here? We'll come to your chair. Have you finished, guys, over there? Yeah? Yeah, good.
It's just a question for local authorities, really, because what DPH is here today is around, from the observations today, we've got an approach from Lancashire County Council, from Blackpool, because unitary authorities. Is there one offer, or what the public health offer is? Because I think each locality, and I'm talking at place level, will get a very different offer about what's available. And I know in Morecambe Bay, we got the support of a public health trainee at Cumbria County Council. What is the level of support that each of the areas are getting from public
okay,
health?
before I come back to your table, I'll let Sakti, maybe, can I pick on you?
Yeah, I'm going to look at Arif as well. It is not a magic that we can just pull out because of the way that we've done. We've been funded, we've been doing the analysis, but there is a history of our local authority colleagues working really together from a public health analytical community perspective. So we do already do quite a lot of JSNAs together. Slightly different picture with Cumbria in your situation, Karen, but within the 3 local authorities in the Lancashire patch, there's quite a lot of joint working happening on the JSNA and all of that. But I would just put a flag here, that isn't, that is part of, but that isn't going to be helping you and frontline clinicians with a list of patients who are complex, that have got debt problems and housing issues and all of that. So that's analysis, analytics 2.0, and that's the excitement of PHM. But there is quite a lot of work that we need to do, even within public health community, to build that level of expertise to be able to bring various person-level linked data sets and the various other modelling and the mitigated scenarios and all of that. So we are starting to put that together. There is already a public health intelligence community there, but they're not going to be able to do it on their own. This is where the joined-up system offer between the CSU, the trusts, the CCGs is going to be really critical. We need to do much more work to make it easy for you.
By the way, I presume these can all be captured, and yeah, there's some great comments coming through on your Slido. So I like this one, really challenging from Tracy. If we're thinking about double running and transfer of services or responsibility for delivering services, we are missing the fundamentals of integration. Thought. So who's going to feed back from this table? And what were you looking at? Thank you.
We were looking at infrastructure as well. So at risk of just replicating what other people have said, I've pulled out a number of points. So just to cover the first couple of questions around data maturity, analytics and capacity and capability, one of the things that we've woken up to a little bit is that we've done a shed load of work recently on workforce planning. We've gone hell for leather at looking at how we can invent nurses, therapists and other clinical staff, and we haven't given a moment's thought to how we build this workforce, any kind of data analytics and data science workforce. So we've gone away to kind of criticise ourselves a bit about that.
Wow, thank you.
And different levels of skill, really, because again, you know, a bit like sort of generating a kind of an advanced nurse practitioner, you know, you can't kind of build them in an academic year. Yeah. So that's something that we've kind of reflected on. Just to sort of the next heading, just to pull something out of leadership. I think one of the things about having a 20-week programme was that we had to convene a team, build a team and get some work done. We didn't do enough engagement with the key leadership in the system. And I think there will be some projects that you can run quickly and easily, but there are others where you're going to need more buy-in and to give people sight of the fact that it's an issue and that's something you want to look at, so you take them on the journey with you rather than reporting on the fab stuff that you did after you finished doing it. I think some of the conversation we had was around how we could answer these questions differently depending on whether we're talking about PCN, ICC level, ICP level or ICS level, because the questions cut at many levels. In terms of population definitions, the thing that we were aware of is that, we've been going hell for leather with risk stratification in our system for quite a while. What we really need to be better minded to is that group of rising risk patients, and I think that's what our project has kind of given us better visibility of. And instead of chasing the kind of hot work and what can we do today, where, you know, what's the clever work we can do? Does anybody want to add anything?
I'm really sorry, Harry. There's shed loads of work for you here. So that's really, and I was really interested in hearing that into the community connector who'd been out to see the person who had a daughter with serious disability and who had cataract, who hadn't had it done and then given up. And then she just said, oh, and then when I went back to see her 4 weeks later, she'd had a cataract done. I thought, blimey, this program's done one thing, it's given someone better sight. Mm. And for me, that, you know, but how do we measure the impact of that? And that's something, it's a rhetorical question, because I'm not, you know, we're going to have to really think through how we create that sense of what change this is having in terms of the quintuple aim. And this was, I knew what the triple aim was when I came in here. I knew what the quadruple aim was. I now know, leaving Lancashire, I can articulate what the quintuple aim is, because you guys are addressing health inequalities in a way which I hadn't really grasped. I'll be honest, I've learned something today, so thank you for that. But that's measuring that, how you're addressing health inequalities, how you're delivering the triple aim is hard stuff. And you're in the forefront of it. Anything else?
I guess just to echo a little bit of what Karen said, I think our reflection was where there were unitary authorities, there seems to be a more kind of joined up way of addressing some of that more complex data sharing.
Thank you. Okay. Any comments from the front that you want to? Okay, don't expose me in public, Sakti. Yeah, no, it's true, but it's as you know, I say that actually population health meets population health management at the community level. And it's this articulation of the health inequalities and how they get addressed, which I think is so important.
I do think there's something here about having the conversations, because in the NHS we are focused on being extremely busy and meeting demand for obvious reasons. But what these discussions are highlighting is that if we're going to become more of a learning, have a more of a learning culture, we've got to put time aside to have these discussions, to talk about the data, to really listen to each other's respective perspectives on things, and work out new solutions. And we don't tend to do that in the NHS too much. So these sorts of discussions and maintaining a way of having bigger conversations are really important.
Thank you, Gary. Yes,
and just briefly, I mean, I hear Amanda saying it much more than others, but those people that have led commissioning organisations would say that they've been told off far more for performance failures like A&E and not about the 10-year difference in life expectancy. Yes. That is shameful, really. That is a failure of the commissioner model. And if we could, as a group of people, get to do stuff that in our house, a multiple application or parts of Burnley or wherever it is, and we could turn that tide, we'd have made a real difference. Yeah. And we've not made that difference in the last 30 years. So I think it is a significant part of a quintuple aim, if you like.
Thank you. Thank you. Right. Anything else from that table? Any other? Okay. What about here? Yes.
We just had three things really that came out. We were interventions. One really was a flexible approach really that Peter and Lucinda have already picked up around how we support PCNs, not necessarily through identifying one PCN and rolling it out, but how we have a more flexible approach to supporting PCNs do some of this work. The second point really was around a standardised approach to collating outcomes and whether we use PAMs or whatever it might be, but how we actually build flexibility and time into the system to allow us to do that in a meaningful way. And the third one really is around VCFS involvement. We've talked a lot on our kind of questions here around workforce planning, and I think we focus very much on kind of health and social care, but actually there's a big piece of work around VCFS workforce planning, and where we're talking about MDT teams and we talk about link workers, we're talking very much about flowing work and kind of patient cohorts out into that sector, and we haven't actually maybe explored what their capacity and capability is to accept some of those patient cohorts. And how do we actually meaningfully work within our, where we've talked before about our control total, how do we actually see funding flow from the top of that pyramid into the bottom of the pyramid and actually put some real kind of emphasis into the prevention and the population health management agenda, otherwise it's never going to work.
Thank you very much indeed. Any thoughts, quick reflections from the front? Gary?
Part of the modelling aspects of this particular project we're on now, we haven't finished that piece of work. So it sounds really boring, you know, how do you sort of cost all this up? I find it really exciting. But how do you cost it all up? And then when you back into what assumptions are being made around what's happening to activity, what impacts are coming out of all the things that are happening in neighbourhoods. So one of the things we got to finish off as part of this project is how do we complete this circle of the work that's being done in primary care networks, the impact it's going to have, what we're already doing, and then the residual benefits that we can get out of that, quantifying that, because then we can start to see how the money needs to flow. So what we need to put into more preventative measures, whether or not it's possible to take the opportunities from the voluntary services and the third sector, and all of those things we can start to get sight of So it does sound rather boring thinking, how do we cost this up? But when you start thinking about how you quantify this, you can then start making those links and put the right incentives to get the money in the right place. So that's an important thing that we've got to finish off. Jackie's going mad over there for...
Oh, sorry, Jackie. Yeah.
You're not going to like this, though. So I agree. And there are quite a few of the integrated care systems across the country that have put their money where their mouth is with some of this already. So recognising that there's a lot of data and evidence to almost give you the proof to invest in voluntary community groups, to support loneliness, to support housing interventions, etc. So I guess what my challenge would be is I don't think you need to wait for lots of evidence. It's already out there. If you know there's an issue with some of it in local areas, put some money into it. And different providers in those systems have agreed to put their budget into different things, and with the risk that that comes in terms of the system control total, but with the belief that it will make the difference. So I think this is also about how you as a system, you as places and neighbourhoods want to take calculated risks because you know it's the right thing to do and there's enough evidence to suggest it'll work.
Okay, thank you.
Well, I'll just respond to that. So what the modelling enables us to do is to quantify what the impact is going to be, so that you can start to see it. So rather than it being, here's the evidence from elsewhere, if you do that, X is going to happen. And we have had a go at doing some of those things. It actually gets the neighbourhoods and the primary care networks to understand what happens at their level and what we should be expecting around activity. So I don't deny what you're saying are things that we can just get on and do, but we can be more systematic in the way that we understand what the impacts are really going to be on the system. And that's the last part of this particular project.
Okay, yes, Peter.
Just to say as well that I heard 5 really great examples this morning of connections and links being made to existing services that didn't require an additional investment. And I think for me, that was a big piece of the learning.
So one of the things we got from Leeds was just looking at how existing services are being used, and just looking at the numbers, you go, there's got to be a massive duplication of effort there. And if they work in an integrated way, you get a win-win. You get reduced effort for the system, but actually we stop making the people on the receiving end do so much work. The people. Okay, are you, where was I? Yes. You okay? Yep, okay. Let's move on to here. Good.
Hi, well, this sort of follows on from the conversation that's just been had. We were looking at infrastructure, and we actually want to change some of your wording for your actions, I'm afraid. We've noted that you've put down for your maturity matrix component, primary care capacity and capability. And following on from this, I really think it needs to be saying neighbourhood capacity and capability, because we need to be looking at the bigger picture, not just primary care, not just medical. We've got health, social care round the table, and that's sort of suggesting just medical, which is what we discussed at our table. And we also looked at the wording, because we've talked about how wording can make such a difference, and it says here identifying funding for backfill. We think maybe if you could say for utilising resources and things, because we don't want to use the capacity we already have. We don't want to be pulling GPs out of surgeries to backfill. We want to be using what's already out there and putting it together. So just a bit of wording that might make this more approachable for other people. One of our actions under the primary care or neighbourhood capacity and capability that we thought should go in is to set up a local neighbourhood board of different sectors. We've done it in Blackpool with Integration 2020, but something similar to be run across to make sure that everyone's voices are heard, and that should include empowered patients who are out there in communities that do want to help but maybe don't know how to voice themselves. So if we could set up a board that included all of that, that would be really useful, and then we could get all that support in one room. And we also looked under the leadership part, and we thought if we can just find some ways to remove some barriers and break them down between the ways that we all work. Sometimes we can try to set up a phone call from one person to another, but their rule is they have to do a face-to-face or they have to write a memo. Can we not break down some of these barriers so that we can all work together in a much nicer, easier way? I know there's rules for a reason, but sometimes if we can break some of that down, the patients can actually, or people out there can actually be looked after in a much better manner. And that would really save some of the resources that we're spending on nonsense at times.
Get rid of the nonsense. Okay.
Yeah, get rid of the nonsense.
Anything else?
No, I think
I'm going to carry on because I think this end of the table had they had a problem, and then I'll get the feedback from you guys. Is that okay?
Thanks. Terrible handwriting here, Harry, so I apologise for this. We looked at the infrastructure, but in particular the information governance part, and from this end of the table, there was a strong voice that said the most important thing we need to do, probably first, is make sure that they establish the legal basis for the ongoing data sharing, data linking, and adding in further data sets, because having that as key part of the infrastructure needs to be done, because everything else will get held up otherwise. We also talked about, this supports interventions, but from an infrastructure point of view, having those standardised frameworks for the development cycle, a standardised approach for intervention design, data capture, evaluation, and all of those things. So where possible, having those, this is the good way of doing it, standardised best practice templates available to everybody. And then the third thing, very much under infrastructure, is actually about the services themselves that already exist. I'm really pushing for the digitalisation of those services and the support to staff themselves to embrace those new tools, new technologies.
Thank you. Good. Have I left anyone out? I've not left anyone out. That's good. So now we come to this group, which did some work as well. Who would like to feed back on your work?
Yeah.
He held the pen.
I had left the thing there. So basically, we were discussing the aligning the contracting and incentives aligned to the PHM methodology, but we ended up talking about wider stuff as well. So essentially, it was all about the process that we need to create to nurture the people that we're here to serve, mainly our residents, but also our workforce, to do what's needed and own the issue locally. We then discussed the roles of senior leadership being the convener of conversations and facilitate frontline staff to enable them to do what they need to do. And then we talked about aligning this with the PCN maturity and the support to the primary care networks. But I totally take the point that we need to be really thinking about neighbourhoods and not over-medicalise it by keep saying primary care, which is a very specific term in NHS. For me, NHS is neighbourhood health system. There's another NHS meaning for you. We then really went into some details about we need to complete 2 more steps in terms of completing the learning and completing the modelling work and showing the impact and finish that piece of work, but then really start to assimilate the learning and then decide how we are going to support the scaling up and spread of the work from 5 to 38, I think it's today. And then there is, in terms of the next steps, there is an ICP, ICS conversation to support the neighbourhoods to do, to help them, particularly around IG and what support we are going to put together for primary care networks or the neighbourhoods. And also, there may be certain things that we may need to do at the at the Lancashire and South Cumbria wide work around agreeing data definitions, agreeing the standards. I think there was another comment made here about can we produce support packs for neighbourhoods to use across Lancashire and South Cumbria in a standardised way using some of the common segmentation work. So that's where we basically said we haven't finished yet. We have just begun.
Thank you very much indeed. Wow. We came here with the intention to come out with helping you create a roadmap, support you collectively with a roadmap which will build on the 20 weeks which you have invested, huge time, energy and effort and application in a way which we from Optum have all found thrilling. It has been an absolute privilege to work with you. And we hope, no, we don't hope, we know that you will take this forward as a community of practice, as professionals, and as a leadership team, and move forward. We will be working with you to deliver the draft roadmap, which then needs to be owned by yourselves, and taking that forward. There'll be some loose ends that we need to tie up. There's a little bit more work being done because we've invested in this, not just sort of intellectually, but also I hope you feel that we've invested in it emotionally as well. So thank you very much. And I'd just like to hand back to Andrew, really, to close and final reflections.
Well, thank you very much. I mean, I think what I would say is that everything that we've heard today, in a sense, re-energises much of the effort that we're trying to make when we talk about integrating care. So we've enjoyed this language of integrating care because this whole notion of joining up things that were fragmented, we felt were fragmented, has been a driver for many people, whether they were frontline professionals or commissioners or analysts, whatever your role might be. And actually, I can remember back at Farrington Lodge, you know, we had the kind of energy in the room there, and we were learning about what a theograph was. But in essence, then, the whole sense was about going back into neighbourhoods and seeing how far we could get. And I hope you agree that the amount of progress that's been made and the amount of learning that's been made, even though it's not finished, as Sakthi rightly just said, it is significant, and it's built on so much of the good stuff that people have been doing in their various places. So thank you again for everything in the last 20 weeks, but certainly everything today. And let's keep going, because we've got so much more to do. Thank you.
Thank you, Andrew.